conversation will be between the gynecologist, who will be Dr. Ingrid Gichere. Dr. Ingrid Gichere, who is an obstetrician gynecologist at the Aga Khan University Hospital. And with her will be the endocrinologist, Dr. Wairagu, who we know as the village doctor, and is a consultant endocrinologist at Gatundu District Hospital. Welcome.
When they're already pregnant, and that is very often too late for me to even change the trajectory of that pregnancy. That one lies with you guys. So the patient you give me is basically what is the basis of a healthy pregnancy. So that's why it's so important for us to talk together and work as a team, and that's what this talk is all about. So I had been basically asked to give some clinical examples. So we have 2 cases we wanted to just present, and then we'll have a discussion in between ourselves. We need to go back to the start of this pregnancy. Now you're revealing everything here. Back. We are not sure. Sorry for that. Now we here we are. Now I'm lost again. I'm so sorry. It's too complicated for us. Yeah. Good. So the first case is a patient with type 1 diabetes. I have one of each, type 1 and type 2. I would just go through it, and some of the things I want you to notice is the thing that are in bold, right? So this was a 34-year-old, para 2 plus 0, gravida 3, at 16 weeks and 3 days. So the 16 weeks and 3 days is highlighted because that makes me so sad. She has come to me very late, right? Her BMI was 28.8, blood pressure was normal. She was diagnosed with type 1 diabetes at 16 years of age, and she was at that time on Mixtard 30 International Unit, AM and PM. So she does not monitor her blood sugar and has not been on regular follow-up, sadly. The latest HbA1c was 1 year ago, and it was 8.23, which of course is a red flag. It's high. So her obstetric history was that she had a pregnancy where she delivered by emergency cesarean section, a large baby, 4.1 kilo, and she developed preeclampsia at 34 weeks. Some years later, she had an elective cesarean section to another large baby, 4.2 kilos, with episodes of severe hypoglycemia in the first trimester. And she also had postpartum preeclampsia. The severe hypoglycemia required admission, and she was unconscious several times. What we did then, we started her on aspirin 150 milligrams, and that should ideally be started at 12 weeks, up to 36 weeks for preeclampsia prophylaxis. It's extremely important because they're at high risk of preeclampsia, and it should be given in the evening. So she was informed about the need for close follow-up, sugar control and diet, and the risk to the mother and fetus was discussed with her, and she was informed of the need for a very detailed anatomy scan at 20 weeks, and the need for growth scan at 28, 32, and 36 weeks to assess for both the small and large fetus. And she was, of course, referred to one of you guys very urgently. And we did UECs, which were normal, and urine albumin creatinine ratio, which was normal. So then she saw one of you, and that was at 18 weeks, and she had poor blood sugar control. The fasting sugars were between 8 to 10, and 2 hours postprandial was up to 17. There was no clinical signs of retinopathy, neuropathy, and nephropathy, and she was changed to Levemir and Novorapid, as you can see. So she was referred to the ophthalmologist and a diabetic educator, and she had these labs done in addition to what we had already done. So lipid profile shows a high cholesterol. TFTs were normal, and she had low vitamin D. So the second and third endocrinology review were done at 22 and 23 weeks. So there was still poor blood sugar control, fasting blood sugar 9 to 10, and 1 hour postprandial was 15. There was an adjustment of insulin, and then she was reviewed after 1 week at 23 weeks, where there was now better control with fasting blood sugars 2.3 to 4, and postprandial was 6 to 8. So we were in a better place, but she had multiple hypoglycemic episodes, so there was a reduction in Levemir. Then she was seen at 25 weeks. I hope you notice that there's no obstetric reviews here. because she kind of forgot those, seeing you all the time. So now she was on Levemir 20 international unit in the evening and on Novorapid 14 international units. Fasting blood sugar was, as you can see, and 1 hour postprandial was now up to above 20. So insulin was again adjusted, as you can see, and she was scheduled for review after 2 weeks. Now, unfortunately, she came to us and forgot about you. So there was no endocrinology follow-up till admission at 33 weeks. So obstetric reviews, she missed the 20-week anatomy scan, which is extremely important, right? Because when you've had poor control diabetes in the first trimester, you're at higher risk of fetal anomalies. So we normally prefer a very detailed anatomy scan at 20 weeks, ideally in fetal medicine unit or with a fetal imaging specialist, including a fetal echo. So she did it at 24 weeks, and it was, thank God, normal. So she had a growth scan at 28 weeks, which showed an estimated fetal weight above the 97th centile, so was already signs of a large baby. Now, again, she missed the growth scan at 32 weeks. So she was admitted at 33 weeks. She had severe frontal headache, 10 out of 10 on pain scale. Her blood pressure was borderline, but there was no protein in the urine, so she was diagnosed with gestational hypertension. She had an MRI of the brain due to the severe headaches, which was normal. And she was on Levemir 20 international unit and Novorapid 18, and the fasting blood sugar was 6 and 1 hour postprandial 9 to 11. So there was an adjustment of insulin, and she was discharged after 5 days in stable condition. So now she came back to us, and we saw her at 35 and 36 weeks. I personally did a scan at 35 weeks, and it was the estimated fetal weight was at 3,087 grams. You can see that's already a bit big at 35 weeks, right? So the overall centile was 88 centile, but the abdominal circumference, which is where diabetic babies, they tend to get a bit obese around the belly, was above the 97 centile. So she was advised on delivery at 37 weeks because of overall poor control and signs of a large for gestational age fetus. And recommended tubal ligation. Remember that she already had 2 previous cesareans. This would be the 3rd, and she's had several complications. So she was booked in for elective cesarean section to be done at 37 weeks, 1 day. And of course, she had an anesthesia review prior. It's very important. So she came the day before the schedule and was admitted with contractions. She had hypoglycemia on admission. It was 1.8 millimoles per liter. And she was given dextrose. And of course, we called in the endocrinology team. And she had an emergency cesarean done, which was uncomplicated. She declined BTL, which made us a bit sad, but we can't force people. And she started on thromboprophylaxis 6 hours after surgery to continue for 10 days and had full course of antibiotics prescribed. The neonatal outcome was a live infant with Apgar 9910, birth weight 3.3 kilos, which was at the 80th centile, and the umbilical cord gases was already showing signs of some level of acidosis, despite her not having only been in early labor. And blood sugar in the baby after birth was 1.8 as well, and the baby was given dextrose. So I think this is a complicated, but not that a typical case for type 1 diabetes in our setup, right? So what are some of the learning points? Is that preconception care is critical, and that is we need to optimize blood sugar control, start folic acid, check for organ damage, and plan the pregnancy. And that one is you guys, much more than me. If they come to me with a pap smear and stuff, I always try remember this part, but it's you guys who is their link to the medical field, and you have to remember to talk to them about this every single time you see them, please. Then tight blood sugar control is essential. Poorly controlled type 1 diabetes increase the risk of macrosomia, preeclampsia, and hypoglycemia, as we can clearly see in this case. And then that insulin adjustment is dynamic. You need regular titration based on self-monitoring and blood glucose, and regular follow-up. Missing follow-ups like skip growth scans and endocrinology appointment worsens the outcome. And of course, it can be overwhelming for a patient that you have to see both obstetricians and endocrinologists. And we have tried sometimes with what is called a one-stop clinic where we sit together. If that's feasible in your setup, then that's recommended. Hypoglycemia needs rapid identification and management to avoid maternal and fetal compromise. And then delivery planning. Emergency admissions can occur even in well-planned cases, so you need to be prepared. So start the planning for your delivery early. Before I go to the next case, is there anything you want to ask me about this one, or we take the questions after? Okay. So that was type 1 diabetes. The next case, I'm actually seeing all the endocrinologists who've been involved in these cases here. So yeah, this patient, she came to me for the first antenatal visit. She was a 36-year-old primigravida at 15 weeks of gestation. And she presented for her first antenatal visit. You can see again, we are late. She was diagnosed with type 2 diabetes 3 years ago. And she was on metformin 500 milligrams twice a day. She had very inconsistent follow-up with her endocrinologist and not done an HbA1c the last 1 year and does not monitor any blood sugar. She's not been on folic acid, preconception or antenatally, and she's never been on any contraceptives, and this pregnancy was not planned. So on examination, the BMI was high. She had class 2 obesity, BMI 38.3. Fundal height was corresponding to her dates, and fetal heart rate was normal. Her antenatal profile was normal, but her HbA1c was 11.3. And that makes the obstetrician go into panic mode. And the reason for that is the graph you're seeing on the side. So you can see the relationship between HbA1c and the risk of major malformations, right? So for her, she's above 10, so you can see we are almost at 20, it says they are 23%. So that's sad and scary. She had an early obstetric ultrasound, which showed a single intrauterine gestation at 15 weeks, 4 days. So she was sent to the endocrinologist urgently and started on insulin and blood sugar monitoring 4 times daily. She was sent to a dietitian and started on aspirin, 150 milligram Nocte. I remember I said it should ideally be started at 12 weeks, but no later than 16 weeks. If it's above that, it's not useful. For anomaly scan at 20 weeks. So this is her anomaly scan. So this is the baby's head. I know maybe many of you do not do many ultrasounds, but this is the baby's head, and the measurement you can see is of the lateral ventricle, and this baby has moderate ventriculomegaly. Had no other anomalies, but moderate ventriculomegaly generally does not have a very favorable prognosis. So we offered her an amniocentesis for chromosomal microarray. That's to check for any chromosomal abnormality, and that one came out as normal. The parents were counseled on any potential developmental delays and other possible underlying condition and referred to our neurosurgical colleagues for further counseling, and they opted at that point to continue with this pregnancy. This is the scan I did at 27 weeks. This is the baby's brain. What can you see? Black. That means that that's all fluid. There's basically no brain tissue left in this baby's head. So this is now developed into severe ventriculomegaly. So what did we do? We had an MDT at 28 weeks with fetal medicine, neurosurgery, and neonatology. And it was assessed by the neurosurgical team that this lesion is not compatible with life or only a vegetative state, since there was basically no cerebral cortex left. We applied the hospital ethics board for permission for late termination of pregnancy, which was granted. And the couple accepted that, and we did an induction of labor, which sadly failed despite several attempts, and she ended up with a cesarean section to a non-viable fetus. So that's a very sad story. So learning points for this one is that HbA1c at conception should be less than 6.5, and a high HbA1c in early pregnancy increases the risk of major congenital anomalies. And preconception care and pregnancy planning is essential, as we have mentioned before, right? Anomaly detection and multidisciplinary counseling are crucial. Ethics and compassionate care, so late termination in severe fetal anomalies must involve the ethics board. You cannot go ahead and do it without that. And of course, family counseling. And you have to respect people's choices. If they choose to continue with the pregnancy, that's also perfectly in order, as long as they've been given all the options. And family planning, which she had never been on, should be a routine part of diabetic management discussion for any women in their reproductive age. And that one, again, is with you guys. Yeah. So take-home message from me is that a multidisciplinary team approach reduces complications of pregnancy in women with diabetes. And I will now ask Anne to come in, and we'll discuss a few of these issues. Thank you very much.
Thank you, Dr. Ingrid, for that well-done presentation. My question is, you have said there are two cases, type 1 and type 2. From your experience, which one is more dangerous?
So I think that might be a notion that type 1 diabetes is always more dangerous. That is actually not true. The complication for both is more or less the same, but the thing about type 2 diabetes is that many of them have additional medical conditions. So they might have typically hypertension, quite severe obesity, lipidemia, etc. So that in itself are risk factors for example, preeclampsia, fetal growth restriction, and many other things. So type 2 diabetes is actually equally serious, if not more serious condition in pregnancy. And it's one we see more and more, especially in our population. And also some of the women tends maybe to be a little bit older, that adds an additional risk. So they are both high-risk conditions of pregnancy, should be managed as an MDT. Yeah.
In your practice, you practice in Aga Khan, what are the challenges or the barriers you find for patients who have pre-existing either type 1 and type 2 diabetes, especially during preconception? Do you face any challenges, cultural barriers or something?
We do. So I think preconception care is the cornerstone of all medical conditions in pregnancy. So not only diabetes, but anything. And I think one of the problems is, of course, that like when I see patients, I'm a gynecologist. When you see patients, you're endocrinologists. Maybe sometimes we forget each other. Sometimes our focus is very much on our own field, and maybe we forget to ask about, like if I'm an endocrinologist, I can only speculate, but do we actually always bring this up, and do we emphasize and check whether the woman is on a safe family planning option? Before, and do we ask, like, what are your thoughts on reproduction? I mean, when do you want to get pregnant, etc. So that is one thing. And then another thing, I'm Danish, but I've lived in this country for many years, as many of you know, but we don't talk always so much about sex. And I'm very happy you brought it up, right? So for example, in a patient with type 1 diabetes, you need to start talking about the challenges of reproductive health already in adolescence, as Dr. Hadi told us. And I think that's super important. So it becomes a natural part of that diagnosis that, yes, I know that when I want children, it's not impossible, I can get children, but I need to plan it, I need to get help, I need to address it early, right? So we need to address it. Then the other issue is, as we just discussed a bit over breakfast, we did a qualitative study on preconception care within our setting, and some of the things that were brought out is like that preconception care is not African, that like this thing of planning for pregnancy or announcing that you want to get pregnant is not normal, and it's sort of, if you say it loud, it might be dangerous to the baby, the evil eye. Yeah, exactly. So this thing of actually showing up in a visit and say, you know, I'm planning to get pregnant might be very unnatural, and something we need to address early to make it feel more normal. And also, like, it's a waste of money to come and say, to do a consultation when I'm not sick, I'm not pregnant, what am I coming for, right? So we need to normalize it and talk about it. Yeah.
Okay. When it comes to the monitoring of the blood sugar, what are the targets, and how often should pregnant someone with diabetes be seen in the antenatal clinic?
So the targets we work with is a fasting blood sugar of less than 5.3 and the 1 hour postprandial less than 7.8. So if you have any different thoughts, let me know. For the antenatal follow-up, so we would have the first visit should ideally be like at around 6-7 weeks, just we know you're pregnant, etc. And then we see them at 12 weeks where we start aspirin, we do screening for aneuploidies, that's routine for all women, not only them. And then we see them probably every 4 weeks, up to around 32 weeks, yeah, and that is just to keep track on everything and do the 20 weeks anatomy scan detailed. We do a checkup at 24 weeks, we do another growth scan 28 weeks, 32 weeks, 36 weeks. And then, of course, we would see them, if we decide to prolong the pregnancy maybe up to 39 weeks, we would at least see them weekly. Yeah.
What about the delivery? Is it better SVD versus cesarean, or what?
So cesarean is only on obstetric indications, and if there's any worry about severe macrosomia, right? So if the baby is estimated to be more than 4.5 kilos, you can consider it because of the risk of shoulder dystocia. But the safest for a diabetic woman is an SVD, less risk of surgical site infection, etc., blood clots, etc. So SVD is the preferred way of delivery. There's no benefit to a elective cesarean section just because of the diabetes.
Okay. What about the comment on the late pregnancy IUFD, and what is the optimal time for delivery?
Thank you. Yeah. So women with diabetes are at higher risk of intrauterine fetal demise, that is especially if your blood sugar has been poorly controlled, if there's signs of fetal macrosomia, or also, of course, growth restriction. So if you have very good control with no signs of that, then you can actually allow up to 39 weeks. If there's poor control, you now need to plan delivery between 36 weeks and 38 weeks. Yeah, but it can still be vaginal, and it can be an induction of labor. So I think our time is up. Yeah? Thank you so much.
So we will now have the question and answer session. So I can ask the other presenters to come up. Then I'll request the delegates, if there's any space in front of you, please move forward so that we can be closer. If you have any questions, you can either raise your hand or you can write it down and pass it on to the ushers.
100% sure, but I doubt it is. But you know, in the gynae practice, it's used quite frequently. It's not something that is not frequently used. Like for fertility evaluation treatment, I see all the time gynecologists request for AMH levels. So the only problem is not even only the availability, but the standardization. So just make sure wherever it is available, it is a standardized test. Like there are studies that have actually been conducted, I didn't have the time to project, which show that there are very, very limited few standardized tests. Like the Roche one is actually standardized. There are others, a few others. So just be careful that you're using a standardized test to do it. And your next question was?
How often should you do it?
Oh yeah, so you should only use it for diagnosis in PCOS, unless now you are evaluating for fertility later. But again, in PCOS, use of AMH for fertility management is not the most suitable way of assessing your follicular reserve, because you have got arrested follicles which are producing that AMH.
Thank you. Those were brilliant presentations and discussions. I really want to thank you. My question goes to Dr. Ruth Karianja. I actually have two questions, but I'll try and keep it short. Number one is we have quite a number of the adolescents, and they start off with their pediatricians very well. Then they get to the age of 18, and they feel awkward coming to the pediatrics clinic, but then they come and they find me with my geriatric patients, so they kind of feel lost. And so you find them kind of lost to follow up. And when they do come, they say, instead of using basal bolus, they use twice a day insulin. And they're like, I've checked my sugars and it's okay, but they don't have any records. So my question is, how can we work together between the pediatrics and the adult endocrinologist to try and bridge this gap? Then number two, you opened a can of worms when you were talking about discussing drugs and about sexual intercourse. I mean, those are very difficult conversations, because if they say, yes, I smoke marijuana, how would you then proceed going forward? I mean, it's very difficult to have such a conversation.
Thank you so much. Those are actually the easier conversations that I tend to have, because I've realized adolescents like the shock factor, so just be ready for the shock factor. But one of the things that I'll talk about what we're doing at Gertrude's is that Actually, the endocrinologists have been very welcoming because they get to focus on the insulin and that bit, and all those other things that are uncomfortable to talk about, they send them to my clinic. And so there are two things that happen. One is that you actually start preparing them for the next step so that it's not as awkward. And if we had an ideal, like what we would want to say as the ideal setup, where you'd actually have doctors sitting together, where you and I would sit together as the pediatrician or the pediatric endocrinologist to be able to sit in the same clinic with the adult endocrinologist. And there are spaces that would work beautifully, like hospitals that are integrated both for adult and pediatrics. And so gradually from age 10, and that's why I was saying 10 is such a key number, is that you actually start telling them, we have the next 8 years to prepare you to start seeing Dr. So-and-so. And we're going to give you things one step at a time so that you're more comfortable being able to have these discussions. And so what you find is that you start talking to the young person instead of the parent. And so I'm always telling the parent, hold on, tell me from your perspective what you understand, and sometimes even kicking the parent out of the room so that they get used to having that one-on-one discussion, so that by the time they get to you, it's not awkward. The other thing is soft handovers, actually talking to them about the adult physician that they're going to meet, where they're located, and being able to refer them, and they already have a document, so someone is already expecting them. When you do ask, and I think it's quite appropriate that you said, okay, Sawa, you ask about drugs. What if they actually give you an answer? What do you do from there? The thing is that at least you are establishing some trust and a therapeutic alliance. So that would be the first step. And then understanding what their goals are in the context of what they want to do with their lives, what they see themselves doing in the context of their illness, and then being able to understand what their understanding is about this drug and the impact it has on these particular goals. That's why I talked about those goals being the hooks. So you'll come back to those things rather than talking abstinence, because abstinence more and more is actually showing us that it's not working. So, and then where you're stuck, please feel free to say, I am stuck, sijui, but let me send you to somebody who can be able to support you with that. Yeah, so thanks.
Okay, Dr. Gaman?
Excellent presentations. A few questions or maybe comments. For Dr. Ruth, how do you handle having less of the parent around during the transition period in view of the fact that you want this person to be, or this person living with diabetes to be independent, and at the same time not make the parent feel like now you've thrown them out and that's it? Yeah. That's the first question. Yeah. The second question was to Dr. Ingrid and Dr. Ann. As a learning point for us here who looked at that type 1 diabetic, could we look at the insulin regime and say, what could we have done different or better with that insulin regime? For the guys who are looking at, 2 basal insulins running together, rapid insulin running several times, are there things we can learn from this case?
Thank you so much for the question. And that validating the experience of the caregiver is so key. And so if we look at the Children's Act, we cannot provide care without permission of the parent. And so usually I will seek the permission at the beginning that this is what we're going to do. There are certain things that I will ask that you're in the room. And I would like to request if you'd be able to step out of the room for certain questions, because your young person may not be able to answer them when you're seated here. Allow us to be able to have the conversation, however, it having some limits in terms of confidentiality, being if I'm concerned about safety, or if there are disclosures made that impact care, then we'll figure out a way to be able to talk together. I have found more often than not, when you start that way, parents are not wondering what's happening in the room. You've sort of given them sort of like the synopsis of what's going to happen. And more, as you talk to the young person, I also do a lot of coaching for parents to sort of let go of the reins, slowly but surely, in terms of if you're the person injecting, and I think in terms of diabetes care, a lot of the diabetic education team have done a phenomenal job of having children inject themselves. I don't find a lot of parents, although recently I've been finding teenagers still being injected by parents, have been removed from boarding school, they're in day school so that mom can keep eyes on you. There's one who was even pulled out of school for 6 months so that she can sit with mom at the office when it's time for medication. So in that scenario, being able to gradually counsel and gradually model for the parent what it looks like to actually let go of the reins. And eventually what I find by the second, third visit, the parent even knows and says, I've gone to drink coffee or I'm just out here. So when they do come for the adolescent reviews, it's actually for both of them. So that sort of separation actually works very well in terms of starting out those steps. And then being able to have the conversation about what the concerns for the parent are, what their challenges are in terms of letting go, and what that looks like for them. Because I always tell them at age 25, when they're sitting in their own apartment, calling you just to give you a heads up, versus sitting in your house with you. Instead of you enjoying empty nest, now you have this 25, 26-year-old who's in your house, who's been enabled in that sense to be in your house. So it's a bit of a balance of the two so that you continue to validate that transition experience for the young person while ensuring that you don't invalidate the caregiver. Thank you so much for the question.
Thank you, Dr. Agman, for your question. Is the issue about the insulin regime. You know, insulin is a first-line management for patients who in pregnancy. As you see, the other drugs, they are contraindicated, metformin, and they can be used. But now insulin, your question, your insulin, which regime? Our patient, we have seen, was on Levemir, which is a basal insulin. Then there was also Mixtard, which is mixed. So I thought that was a type, I don't know, I thought when I saw it, I was like, these are the patient will be at risk of going to hypo. I think the Mixtard was even the TDS. So the best should be like a basal bolus regime, where the patient get all the basal and the boluses during mealtime. So that should be an ideal way of managing this, especially the type 1 diabetes. Then for those one who are now, you can transit to the Mixtard. You can use a Mixtard. It's also, all the types of insulin are safe, but now the combination is, I think that's what was your question, that it was not looking quite good. About the orals, maybe I may still comment on that. Now that I've managed that. So the orals, metformin has been shown that is safe. So many studies have shown, yes, it crosses the placenta barrier, but there's a concern about growth restriction on the child, and maybe later on those children, they're found to have an increase of weight, risk of going to increase of weight. Glibenclamide has been, it does not close the placenta barrier. For those one who come from resource poor setting, then may use the glibenclamide, but is not recommended by most of the ACOG and the ADA. They don't recommend glibenclamide, but can be used. But the insulin, all the insulins are safe, but now with the dose adjustment according to the trimester and the glucose monitoring, the CGM comes in quite handy in trying to monitor closely the blood sugar and adjust the insulin accordingly.
Okay, we'll take 2 questions from the floor. And
maybe just to add on to that. So again, I think one thing is to emphasize is that basal bolus is the best regimen for pregnancy and diabetes of any type, whether it's if it's gestational and you are requiring to use insulin, or whether it's type 1. Of course, for type 1, basal bolus is the recommended regimen. And it doesn't have to be analog insulin. If you have a resource-restricted setting, then you can still use a long-acting insulin like either Levemir or Glargine, or if even that is not available, then NPH where applicable, yeah? Although it will need to be given twice with a short-acting insulin like your human insulin, like regular insulin. So ideally we should try and aim as much as possible to stick on to basal bolus regimens. And I think like what Dr. Gaman was asking is having a mixed insulin regimen with a long-acting insulin, which both have a long-acting or at least an intermediate component. We should probably just, I don't know, be avoiding that, right?
So the first question is, you said in the management of PCOS, COCs were part of the management, and we understand that COCs, they have a side effect of weight gain. So for a patient who is obese, is having PCOS, and then maybe you want to use COC to balance the hormones, what happens in that case? And then the second question goes to Dr. Ingrid. What is the earliest, when do you recommend, for a person who has conceived, we can say unplanned pregnancy with diabetes type 2, HbA1c was high, more than 6.5. What is the earliest that you recommend they see you? At what week? And then have you experienced a case whereby the patient is having an elevated HbA1c and they go ahead and deliver safely without any complication? Thank you.
Dr. Musheru, and then we'll combine the answers for the two.
Okay, thank you. Thank our speakers for the excellent talks. So I have 3 questions. Dr. Saira, what is are there different cutoffs for the AMH depending on the phenotype, like the lean phenotype and the other phenotypes when it comes to diagnosis? And is there a role for AMH other than diagnosis? Is there any other role for AMH in PCOS? And then for Dr. Ingrid, what is is there a role for earlier screening given the increased role of, or rather the prevalence of diabetes? Is there a role for earlier screening, probably even in the first trimester for women, to screen them for gestational diabetes? And finally, to our dear pediatrician, given the complex interplay between maternal hyperglycemia and fetal programming, how do you evaluate or examine these patients long term, for development of obesity and type 2 diabetes and insulin resistance and so forth and so on. So these are kids who are born to mothers who have either gestational diabetes or type 2 diabetes. Thank you.
Can I
I don't know if you want us to answer all of them.
Just answer them, and because
Quickly,
we have
yeah.
limited
So,
time, just
yeah,
be
so
brief
I
with
think
the
the
answer.
issue of COCs is real actually. So we always work with our gynecology colleagues as well before we even initiate. And please do that, yeah, because there is a whole risk assessment for COCs before even starting them. And obesity is one of them, especially stage 2 onwards for obesity, right? BMIs of 30 and above, you need to assess. So in that case, first of all, obviously, lifestyle modification is excessively key. Please send your patients to a dietitian to get help, to assess. An exercise regimen could help as well. And the attempt to weight loss is key in this case as well, because it also helps with menstrual regularity. That's a patient I would also consider combination with metformin. So it's like you give a combination, and if they're at very high risk, then you don't give the COC, you give only metformin with the rest of the lifestyle modification. The question, I think I've answered that. So the question on AMH, so like I showed you the Aphrodite trial, the study, that is the one that is being used to use the cutoff of 3.2. And basically, it showed that it performed well in all phenotypes. It is not a restricted level. It's just where you require is where you do. Don't just do for all patients with PCOS. We don't yet have a cutoff for diagnosis of PCOS. This is for diagnosis of PCOM, the polycystic ovarian morphology. I think I answered that.
Okay. So the question about whether I've ever seen a pregnancy with a high HbA1c turning out normal, of course, like the majority would turn out normal. So as you could see with our the graph I showed you, like with above 10 now, the risk of anomalies is very high, but there's still a higher chance that the baby will be normal. So a high HbA1c in itself is not an indication for termination if it was otherwise an unwanted pregnancy, right? So for sure, we've seen many of those. Then you asked when we should see them. So ideally, as soon as they know they are pregnant. So I mean, if they come like in the early first trimester, like 6-7 weeks, so that we can discuss the risks and start them on relevant treatment, etc. So yeah, we need to see them. So for you guys, what you need to do if they want to get pregnant is to make sure that they are on safe drugs, stop ACE inhibitors, etc., which is teratogenic, start them on folic acid, and ensure that the glucose control is good, less than 6.5, at least less than 7, before pregnancy should be attempted, and assess for end organ damage before they come to us. But we should see them in early pregnancy, and ideally you should send a patient who express a wish to get pregnant to us for a discussion first, right? Then I'm being asked in the second case, which was the case of type 2 diabetes with the ventriculomegaly, is there a relationship between the age at 36 years of old and the outcome of the pregnancy? So the risk of anomalies in itself does not increase with age. The anomalies that increase with age is the one that are related to chromosomal abnormalities. So the older we are, the higher risk of chromosomal abnormalities. And remember that her chromosomal testing was normal. What was her other risk factors for anomalies beyond the diabetes was her high BMI. So we know a high BMI in itself is a risk factor for anomalies. So of course there's no one here who can say that her anomalies were associated with the diabetes 100%. We only know that her HbA1c was very high, and the type of anomaly she had is known to be associated with diabetes. Yeah.
Okay, thank you. I'm glad it has generated a lot of conversation, but in the interest of time, we'll stop there. Can clap for our presenters. Our presenters will be available during the tea break